Dislocation of shoulder joint. Dislocation of shoulder joint is very important because it is the commonest dislocation in the body. Why? Why dislocation of shoulder is the commonest dislocation? First of all, this is the dislocation of shoulder. First of all, compare the articular surface. Shoulder joint is articulation between glenoid cavity and the head of the humerus. Is the size of the glenoid cavity is suitable and proportionally well to the head of the humerus? Of course not. There is a shallow, small glenoid cavity like this. This is the glenoid cavity, is small and shallow, while the head of the humerus is large head of the humerus. In addition, the stability of any joint depends upon well support by strong capsule, strong muscle, and strong ligaments around the capsule. In our case, in the shoulder joint, there is weak surrounding capsule, weak surrounding muscles, and weak surrounding ligaments. In addition, the range of movement of shoulder joint is the widest range of movement in any joint all over the body. Therefore, wide range of movement, weak surrounding capsule, muscle, ligaments, and shallow small glenoid and large head of humerus make the shoulder joint unstable and the commonest joint to be dislocated. There is a rim of cartilage present around the glenoid cavity to deepen the glenoid cavity. This rim of cartilage called labrum glenoidal. But in spite of presence of labrum glenoidal, the glenoid cavity is still shallow and very common dislocation of shoulder joint. What is the classification of shoulder dislocation? The commonest dislocation is this. What is this? Anterior dislocation. And this will be discussed in full details. Let us take the rest complication first. Or the dislocation may be like that. This is a normal shoulder joint, and this is displacement of head of the humerus posterior to the glenoid cavity, and this is called posterior dislocation. There are two degrees of this dislocation. Minimal degree, and this is the commonest. Posterior dislocation, the head of the humerus becomes below this bone. This bone is called acromion process. And if the head of the humerus below the acromion process, this is called subacromial dislocation. And it is the commonest posterior dislocation. And rarely the head of the humerus becomes below this bone. What is this bone called? This bone is called spine of scapula. And if the head of the humerus below the spine of scapula, this dislocation is called subspinous dislocation. And we should notice that all types of posterior dislocation already rare, because the commonest dislocation is anterior dislocation. Very, very rarely this dislocation, which is called inferior dislocation. What is inferior dislocation? Inferior dislocation is the head of the humerus dislocated and glides on the lateral border of the scapula with fully abducted arm, like this patient. Because the arm is fully abducted, this is inferior, a case of inferior dislocation with fully abducted shoulder joint. This is called luxation recta. Luxation erecta, because the arm is erected and abducted. Let us discuss in full detail the commonest dislocation, which is anterior dislocation. Anterior dislocation, what is the trauma? As usual, the commonest trauma for all fractures and dislocation in the upper limb is falling on outstretched hand, and also may occur due to forcible extension and external rotation. Forcible extension of shoulder and external dislocation of abducted arm, like this. This is extension of shoulder, abduction, and forcible external rotation. Tuck. What is tuck? If forcible extension, abduction, and external rotation, the head of the humerus is impacted against the anterior part of the capsule of shoulder joint and the anterior part of the labrum glenoidal, and the forcible extension, abduction, and the external rotation will lead to rupture of the anterior part of labrum glenoidal and the anterior part of the capsule of shoulder joint, leading to anterior dislocation. What are the types of anterior dislocation? Anterior dislocation usually and commonly, the head of the humerus dislocated anterior to the glenoid cavity. Just the head of the humerus becomes below this bone. What is this bone? This bone is called coracoid process. And because the head of the humerus below the coracoid process, this is called subcoracoid dislocation. Or the head of the humerus rarely becomes just below the glenoid cavity, and this is called subglenoid dislocation. Or the head of the humerus may be displaced medially, very deep inside the axilla, below this bone. What is this bone called? Clavicle. Therefore, the head of the humerus below the clavicle, therefore it is called subclavicular dislocation. Very rarely, very rarely, the head of the humerus may enter between the second and the third rib, and this is called intrathoracic dislocation, and this is very rare. Therefore, the commonest is subcoracoid dislocation, rarely subglenoid, subclavicular, or very rarely intrathoracic. What are the complications of anterior dislocation? First of all, joint complication. Joint complication, as we said before, usually during anterior dislocation rupture of the anterior part of the capsule of the shoulder joint and rupture of the anterior part of labrum glenoidal. This lead to the cartilage doesn't heal and the healing of the capsule is poor, and usually the rupture in the labrum glenoidal and rupture in the anterior part of the capsule persist. Therefore, when the patient always do this movement, tack, the head of the humerus comes in front of the rupture in the capsule and labrum and dislocate again. Therefore, the commonest recurrent dislocation all over the body is dislocation of shoulder joint. During dislocation of shoulder joint, the patient feel severe pain, and due to this pain, the patient fear of moving this shoulder again, and the patient is delayed in movement of shoulder joint. Delayed movement of any joint after injury leading to stiffness of the joint. After joint complication, which is recurrent dislocation and stiffness, bone complications. What are the bone complications? Associated fractures. With dislocation, fracture may occur, like this fracture. The condition may be associated with fracture greater tuberosity or lesser tuberosity or fracture cervical neck. And we all know fracture with dislocation, this is called the fracture dislocation. And this makes the treatment complicated and need operation, reduction and internal fixation, etc. Muscle complication. Muscle complication, the muscle attached in the top from the upper part of scapulum, area called supraspinous fossa, muscle bus to be inserted in the top of the greater tuberosity, a muscle called supraspinatus. During dislocation and the greater tuberosity is displaced. Due to displacement of greater tuberosity, rupture of supraspinatus may occur. Also, from the subscapular fossa, passing a muscle to be inserted in the lesser tuberosity, and this muscle is called subscapularis. Due to displacement of lesser tuberosity during dislocation, displacement of lesser tuberosity leading to rupture of subscapularis. Therefore, supraspinatus and subscapularis are affected by tear in their tendons of insertion. Nerve complication. Nerve complication, here there is a famous nerve. In anatomy, we take a nerve, pass around the surgical neck of the humerus. This is the surgical neck of the humerus, and there is a nerve passing here, around the surgical neck. We all know that any structure pass around a structure is called circumflex. Here there is a circumflex, or also called the axillary nerve. And during dislocation and displacement of the head downward, neuropraxia of axillary nerve and its origin, which is posterior cord of the brachial plexus, may be affected by a minimal degree of nerve injury called neuropraxia. And neuropraxia is characterized by spontaneous recovery within about 3 weeks. Because in neuropraxia there is no structural damage. No structural damage in axon or in the nerve sheath. There is also a shock in the nerve called neuropraxia, and the nerve recovers from this shock within 3 weeks. We all know that in the axilla here, passing axillary artery, and during displacement of the head of the humerus into the axilla, rarely there may be damage or injury of axillary artery, but this is very rare. Therefore, there is joint complication, recurrent dislocation and stiffness, bone complication, fracture dislocation, muscle tear supraspinatus and subscapularis, axillary nerve injury, and the posterior cord of the brachial plexus is very rare. Axillary artery injury is very, very, very rare. This is the types of anterior dislocation. What is the clinical picture of anterior dislocation? Sure, there is history of trauma, followed by absolute loss of movement. Absolute loss of movement means loss of active and passive movement. And this differentiates any dislocation from any fracture. In any fracture, there is loss of active movement only. If you ask the patient, move your injured part, the patient tell you, it is painful, never, I can't. But if you want to move the part, it will move because the joint is intact and the axis of movement is present. Therefore, in fracture, there is painful limitation of active movement by the patient. But in dislocation, there is no axis of movement. There is loss of active movement because it is painful as fracture. And if the doctor try to move the joint, never, because there is no axis to move this joint. Therefore, absolute loss of movement in dislocation means loss of active and passive movement by the doctor, which is passive movement, and by the patient, which is active movement. In fracture, there is limitation of active movement only because it is painful, but passive movement by the doctor is intact. There is sure severe pain and tenderness over the shoulder region, and the most important in any fracture or dislocation is the deformity. Look for the normal shoulder, which is rounded and bulging. Why rounded and bulging? Because the deltoid muscle is elevated by this underlying bone, which is this bulk of bone. This bulk of bone, which is called greater tuberosity. Presence of greater tuberosity elevates the shoulder region and elevates the deltoid, gives this rounded contour of normal shoulder region. But if the humerus is displaced medially, the deltoid become falling straight, leading to this flat shoulder with prominent acromion process. this is the dislocation. This is normal. And the deltoid is elevated by the greater tuberosity. When dislocation occurs, there is flat shoulder and the acromion process become prominent. And the humerus becomes where? This is the humerus, bulging below the coracoid and the clavicle. Therefore, the upper limb appear originating from below the acromion and below the clavicle. And sure, the weight of the limb will pull on the dislocated shoulder, leading to severe pain. To avoid this, sure, the patient will support the dislocated shoulder by the other limb. And usually the limb present in the characteristic deformity, which is during a trauma, abduction and external rotation. But if falling on outstretched hand, actually this will not occur, and no abduction and no external rotation. Therefore, this patient is falling on outstretched hand with no forcible abduction and external rotation, and therefore the arm is not abducted and not external rotated. Very, very important, feel the head of the humerus. Normally, the head of the humerus is felt in the normal position. But in this patient, the head of the humerus is felt below the coracoid process or below the clavicle, because it is displaced medially and downward. Here. Measurements. Measure the length of the upper limb. Measure the length of the arm. The arm is measured. The length of the arm is measured from this bone, which is the acromion process, to this bone, which is called the lateral epicondyle of the humerus. Measure from the acromion process to the lateral epicondyle. Measure from acromion process to the lateral epicondyle. In case of dislocation of shoulder, there is lengthening of the arm. The arm appears longer. Why? Because in dislocation, the humerus always dislocated anteriorly and by the effect of gravity descend downward, leading to wide separation of acromion from the lateral epicondyle. Normally the upper limb is measured here from acromion to lateral epicondyle. If the humerus displaces downward here below the coracoid or below the glenoid or below the clavicle, the head of the humerus descends downward, the whole humerus descends downward, and the lateral epicondyle descends downward and becomes far away from the acromion process with lengthening of the arm. Also, palpate your axilla. The axilla is called the armpit because it is concave. Normally, the axilla is concave. But if the head of the humerus bulge here in the axilla, there is obliteration of the concavity of the axilla, and measure the circumference of the axilla. If you measure the normal circumference around the axilla, with the axilla concave in the normal side, say it about 20 centimeters. But when the axilla here becomes convex by the head of the humerus, you will find the circumference of the axilla is about 23 or 24 centimeter in diameter. Therefore, due to presence of the head of the humerus in the axilla, there is obliteration of the concavity of the axilla and increase its circumference. There are very important special tests. What are the important special tests? Ask the patient, please, can you do this and this? What is this? Adduction of the arm and the medial rotation of the upper limb, which is the reverse of deformity, and there is loss of movement. The patient with characteristic deformity with abduction and external rotation never can do adduction of the arm so that the arm touching the chest, and never the patient can do internal rotation so that the hand touching the other shoulder. Another important test is ruler test. What is the ruler test? Normally, if you put a ruler which is a straight line, you in the normal side of the patient, can you put a ruler and touch the lateral epicondyle and the acromion process at the same time? Never. If the ruler passes here, never touch the acromion. But if the head of the humerus displaced medially and no bulge of the greater tuberosity, you can put a ruler a straight line with the lateral epicondyle and the acromion process. Due to loss of roundness of the shoulder and the loss of greater tuberosity and bulging deltoid, you can touch the acromion process and the lateral epicondyle in the same time. Sure, never forget to ask the patient to try to abduct the shoulder. Abduct the shoulder after sure correction of the deformity. After correction of the deformity and after treatment, ask the patient to do abduction. If there is failure of initiation of abduction, there is injury of supraspinatus. And if the patient cannot do abduction from 15 to 90 degree, there is paralysis of deltoid muscle due to injury of axillary nerve. And touch the patient and test the sensation in the lateral aspect of the arm, which is supplied by axillary nerve. Therefore, examine this patient to detect associated injuries in the axillary nerve by sensation in the lateral aspect of the arm, and after reduction of the dislocation, ask the patient to do abduction to test the deltoid muscle and the supraspinatus muscle. This is a clinical picture of this patient. What is treatment and investigation? Shoulder plane X-ray will show the dislocation, and here MRI is very important to detect associated injury in the ligament, labrum glenoidal, supraspinatus, subscapularis muscle, to detect injury of soft tissues. What is the treatment of this patient? Reduction usually done by Kocher method. What is Kocher method? Traction on the abducted arm, then external rotation of the abducted arm, then adduction and internal rotation. You don't understand anything, sure. Look for this. This is a dislocation. We do traction on the abducted arm. This is the abducted arm. Traction on the abducted arm. Then external rotation. Traction and external rotation will bring the head of the humerus in front of the glenoid cavity. Traction on the abducted arm and external rotation. Then adduction and internal rotation will bring the head of the humerus into the glenoid cavity. Traction on the abducted arm. Then external rotation. The head of the humerus becomes in front of the glenoid, opposite the glenoid. And adduction and internal rotation. This is the usual method. There are other methods for reduction like this. This is called Hippocrates method. The doctor put the unbooted foot in the axilla to produce counter traction with traction on the abducted arm. The head of the humerus will jumping into the glenoid cavity. Or hanging arm technique. Put the patient on this position and the weight of the limb in prone position and the weight of the limb hanging beside the bed, and put a weight in the rest region. This weight will produce traction and the bed will produce the counter traction with reduction of the shoulder joint. Or traction and the counter traction technique. Traction by this method with the doctor counter traction on the abducted arm. Finally, this is the way for fixation of this patient. The patient is suspended in sling with bandage of the arm to the chest in adduction and internal rotation. Sling with bandage of the arm to the chest in adduction and internal rotation for 4 weeks. Open reduction and internal fixation is indicated only if there is associated fracture. Rehabilitation is very, very important to prevent stiffness, early movement of shoulder after 3 to 4 weeks, and movement of elbow and fingers from the first day. In recurrent dislocation, this needs surgery to repair the rupture in the capsule, to repair the rupture in the labrum glenoidal, and to repair any tear in supraspinatus or subscapularis. This is the anterior dislocation of shoulder joint. Thank you for good listening and good luck.